Okay, let's unpack this. We're scrubbing in for a deep dive into what might be the most anxiety-inducing part of a total knee replacement, the patellofemoral joint.
Uh-huh.
And this isn't just about successful implantation or getting the alignment perfect. For us, this is really about avoiding that one looming structural complication that can just completely derail a patient's outcome.
You mean the dreaded paraprosthetic patellar fracture.
Exactly.
And, this topic is mandatory reading. I mean, especially for anyone standing on the assisting side of the table. You really have to understand that the patella isn't just some aesthetic cover for the femur.
It's the fulcrum.
It is the fulcrum of the entire extensor mechanism.
Right.
When it fails, the patient fails. Simple as that. So today we're reviewing a really critical piece of surgical intelligence. It's a sophisticated finite element analysis that shows us in almost agonizing detail exactly how stress redistributes inside that bone after we resurface it.
So the idea is if we can understand the physics of failure, we can prevent it.
That's the hope.
The mission, then, is pretty clear. We're analyzing this FEA study, which investigates how that critical strain distribution changes when you go from the natural native patella to the implanted resurfaced state.
And it's using subject-specific models, which is key.
Right. They're stress testing individual people's knees, not some generic mannequin. Our holy grail here is to pull out simple, measurable factors, the preoperative data points that let us identify high-risk patients before we ever even make the cut.
We need to replace our intuition with hard engineering data.
Yeah.
And the source material here, it's a real breakthrough because it moves beyond the limitations of older methods. Things like cadaveric studies or those simple surface strain gauges.
Right, which only give you a snapshot of one spot.
Exactly. Here, we're looking at a dedicated finite element investigation that focuses on the patella. It moves beyond just two-dimensional clinical imaging to actually map the the volumetric strain deep within the bone itself.
So it's high-fidelity stress testing.
It is. It's giving us a view of structural integrity that you simply cannot get from a standard AP or a lateral X-ray.
Okay, so let's ground ourselves in the clinical reality here for a minute. TKA is, without a doubt, one of the top orthopedic successes of the last century.
Oh, absolutely.
But if you talk to any high-volume arthroplasty surgeon, they'll tell you the patella is still the Achilles heel of the operation.
It really is.
Even with what looks like perfect technique, complications persist. The literature shows we're dealing with an average incidence of chronic anterior knee pain that's, hovering around 12%.
That's right, about 12%. And that's a significant number of patients who, despite a technically successful procedure, are fundamentally just not happy with their new knee.
That 12% is this constant, irritating baseline.
It is. But the real catastrophe, the thing we all dread, is the patellar fracture. Now, while the absolute incidence might seem numerically small compared to the number of primary replacements we do,
the sheer volume of TKAs is huge.
the volume is enormous. So these small percentages translate into hundreds, maybe thousands of major structural failures every single year worldwide. We have to internalize these rates.
Okay, so what are the numbers?
Well, if you look at the large cohorts, the reported rates are pretty sobering. You see 0.68% in a massive series of over 12,000 knees.
Okay.
But then it climbs to 1.14% in another cohort. Then you see 3.8% in a group of about 4,500 knees. And in some populations, it spikes as high as 5.2%.
Wow, that's a huge range, from less than 1% to over 5%.
And that wide range is very telling. It suggests that, variations in patient selection or surgical technique or maybe even a specific implant design can dramatically influence the risk.
So it's not just one single variable to blame.
Not at all. And when these patellae fail, they don't fail neatly.
Right, you have to categorize the catastrophe because the fixation options are completely different depending on how it broke. We see everything, right? Transverse fractures.
Which are usually tensile failures, yeah.
Yeah.
Vertical fractures, avulsion injuries, and then the really messy ones, the comminuted fractures that just look like someone took a hammer to the patella.
It's a mess. And the location data adds another layer of complexity. It shows the forces are all over the place. Goldberg and his colleagues reported that about 40% of fractures happened in the superior or mid-body region.
And 30% at the inferior pole.
Right. But then you look at the series by Ortiguera and Berry, and they give a slightly different breakdown. They found 28% superior, 18% inferior, but critically, 23% were comminuted.
And another 13% were vertical.
The fact that the mode and the location are so varied tells you we're dealing with a complex interplay. It's systemic bone quality meeting localized stress risers. The bone is just failing wherever the local strain exceeds its local yield strength.
And the part that makes this FEA work so absolutely critical is what happens next. The abysmal outcomes associated with trying to fix one of these things. I mean, a patient comes in hoping for a cure for their arthritis, and a fracture turns their TKA into this high-stakes salvage operation. It's a descent into a very, very difficult clinical scenario. And honestly, it often ends in disaster. The outcomes that are reported are consistently and uniformly poor, sometimes shockingly so.
Like what?
When you have a high complication rate of around 50% and reoperation rates near 42%, you're looking at failure rates that are approaching the success rates of a complex primary surgery.
I saw that Goldberg and his team reported 72% unsatisfactory outcomes
72%.
in knees that were revised specifically for a patellar fracture. That should be a siren call for all of us.
It should. The surgical fixation often fails because you're trying to put screws or wires into these small osteoporotic fragments that have already proven they can't withstand physiological load.
You're trying to build a sandcastle on an unstable foundation.
That's a perfect analogy. And let's not gloss over the deep infection rate. Keating and colleagues reported a deep infection rate of 45% for operatively treated fractures.
Wait, 45%?
45%. I mean, think about that for a moment.
That's almost 1 in 2 patients.
It is. That is an infection rate higher than many high-risk cancer reconstructions or complex trauma surgeries. It's astronomical.
Why is it so high? Is it related to the integrity of the soft tissue envelope around the knee?
It absolutely is. With the patella fractures, especially in a comminuted way, it often disrupts the crucial soft tissue attachments and, importantly, the local vascularity.
The blood supply is already pretty tenuous.
Exactly. It's tenuous, mainly coming from the geniculate arteries. A fracture compromises that supply. Then the necessary surgical intervention, which often involves extensive exposure, internal fixation, sometimes even a partial paddlectomy. It further damages the extensor mechanism's ability to heal and the knee's defense against pathogens.
So it turns the whole knee into a high-risk zone for infection.
It does, which is why prevention is always, always the best treatment.
Okay, so before we dive into the computational physics, we should acknowledge the risk factors we already try to manage clinically. What are the established surgical and patient-specific factors that we're trying to predict or mitigate right now?
We've pinned down a few clinical culprits over the years. Meeting and his group highlighted that certain patient characteristics increase risk, notably a body mass index over 30.
Okay, BMI.
And male gender. Operationally, factors like a lateral retinacular release, which can compromise vascularity and stability, and also using a really large patellar component size were strongly correlated with fracture.
And resection depth is always a key factor, right? How much bone you take off.
Indeed. Dallery and Dennis reported that both the final post-operative patellar thickness and, importantly, an asymmetrical resection are crucial contributing factors.
But these are all intraoperative things we can control.
Correct. They're all intraoperative. What this FEA study is designed to do is give us a preoperative lens. It's trying to quantify why one patella is inherently weaker than another before we even touch the scalpel. It focuses on intrinsic structural properties like bone quality and geometry.
So we can protect that subset of patients who are kind of biologically destined to fail if we just stick to a standard surgical plan.
That's the goal.
Okay, let's step out of the OR and into the lab, because here's where it gets really interesting. Traditional methods were just hitting a wall. Previous studies using simple strain gauges were helpful, I guess, but they're so limited. They only measure 1 point on the surface of the bone. It's a surface snapshot.
And that just doesn't tell you what's happening in the deep cancellous core.
Which is where so many of these compressive failures seem to originate.
Precisely. We need volumetric insight. Strain gauges fail because they're localized and they're uniaxial. The key mechanism of failure in TKA is often compressive failure, deep within the cancellous bone, which is, of course, a structural element we remove when we resect and resurface. We need a full three-dimensional subject-specific map to really understand the total load distribution across the entire volume of the bone.
And that's where subject-specific finite element analysis, or FEA, comes in. It's the necessary evolution of our testing methods.
It is. The objectives of this study were methodologically very rigorous. First, they had to develop these subject-specific FE models for 8 male subjects, capturing the patellofemoral joint mechanics during deep flexion.
And crucially, these models had to incorporate density-mapped material properties, right? Pulled directly from CT scans.
Directly from the CTs. Second, they had to quantify the differences in strain distribution between the native natural state and the implanted state. And then finally, they assessed the consistency, or the lack of consistency, across all 8 specimens.
So they're trying to pinpoint the role of an individual patient's bone density and their specific geometry in predicting how it's going to respond structurally.
That's it.
Let's detail the technical backbone here, because this is the core intellectual genius of this paper. The data translation pipeline. I mean, how do you take a sterile clinical CT scan and turn it into a realistic, structurally accurate biomechanical model? That is not a trivial task.
No, it's not. It requires a bridge between radiological data and mechanical properties. So the models were constructed using CT and MRI data from the 8 subjects. They meticulously reconstructed the geometry of the patellar, femoral, and tibial bones, and they even included the cartilage.
Okay.
The key, however, is the material properties mapping. Raw CT data provides Hounsfield units, or HUs, which are really just a measure of radiographic density. And these HUs correlate linearly with apparent density, which we call rho.
So the density of the bone, which is highly variable, especially in an osteoarthritic patient, that's the starting point for calculating its structural strength.
That's right. But here's the critical nonlinear step.
Yeah.
To assign the mechanical properties, specifically Young's modulus, or E, which is a measure of stiffness, the researchers had to use Keller's power law. The equation is E equals 1990 times rho to the power of 3.46.
And that nonlinear relationship means a small change in density leads to a big exponential change in stiffness.
A huge change.
Wait, I remember this from our biomechanics lectures. Why is it absolutely critical that they apply this modulus calculation before they average the density values over a computational element? Couldn't they just average the HUs for an element and then plug that average into the power law?
Ah, that is the subtlety that separates accurate modeling from garbage modeling. And it speaks directly to the inherent heterogeneity of bone.
Okay.
If you average the density first and then calculate the modulus, you introduce massive errors because of that nonlinear relationship. But think of it this way. Imagine you have 2 sections of a patella. Section A is very dense and stiff. Let's say it has a 10 GPa modulus.
Yeah.
And section B is very soft and porous, maybe a 1 GPa modulus. The average modulus would be 5.5 GPa.
Right. Makes sense.
But because of the power law, if you calculate the modulus for every tiny unit of bone before you average, you accurately capture the fact that the soft, porous section, the 1 GPa section, is going to fail long before the dense 10 GPa section even begins to really strain.
I see.
If you average the density first, you smooth out those critical weak spots. The FEA authors specifically used an algorithm where the HU values are transformed into E values for every tiny voxel prior to averaging over the elements. This is essential for accurately locating the strain concentrations in the softer cancellous bone.
It's like checking a wooden bridge. You don't average the strength of the rotted planks with the new ones. You identify every single weak plank because the bridge will fail at its weakest point.
That analogy is perfect. It's exactly why we have to treat bone as a structurally heterogeneous material. And you can see this heterogeneity mapped visually in their figure 22.1b. It shows the patellar bone color-coded by the mapped stiffness, and it demonstrates just how much that density varies even within a single patella.
So let's look at the model construction details. The patellar bones were divided into these massive digital meshes using, 4-noded tetrahedral elements with an average edge length of 1 millimeter.
1 millimeter resolution, which was a necessary compromise to accurately capture those density gradients we just discussed, while also keeping the model computationally feasible.
And the scale of data here is just staggering. For you listening, the researchers were managing about 140,000 elements for the natural patelli models.
This is a huge amount of data.
That's 140,000 points of calculation and interaction just to simulate one small piece of bone in motion. The implanted models were a bit fewer, around 85,000 elements, partly because the component replaced some bone, but the complexity is still enormous.
It is. And to keep the computation manageable, they had to make some smart compromises. They had 2 models per subject. The natural one and the implanted one, which included the domed patellar button, the femoral component, and the tibial insert.
But critically, for efficiency, the femoral and tibial bones and their components were modeled as rigid bodies.
Right.
Why the rigid body assumption for the femur and tibia Does that sacrifice any fidelity in the model?
It saves an immense amount of computational power. We're primarily interested in the internal strain of the patella. Modeling the femur and tibia as deformable bodies would easily triple the element count without giving us much more insight into the patellar strain itself.
So you're assuming their deformation is negligible compared to the patellas.
It's a reasonable assumption. Under these isolated loading conditions, the stiffness of the femur and tibia vastly exceeds that of the patella. We accept that simplification to make the study possible while ensuring the components we are studying, the patellar component and the cement layer, are fully deformable.
And the component positioning was clinically guided, which is essential for external validity. They were placed in a neutral, simulated surgical alignment.
Right. Finally, the dynamics. The loading conditions.
Yeah.
How do you simulate a deep knee bend? Well, they used an isolated patellofemoral, or PF, joint model. It included 2D fiber-reinforced membrane representations of the entire extensor mechanism.
So the patellar ligament, the quad tendon, the PF ligaments.
All of it. You can see it in their figure 22.2.
And what about the force application? How did they load it?
The simulation mimics the transition from rest into deep flexion, specifically 120 degrees. First, a small 300 Newton load was applied to the extensor mechanism just to get stable contact between the patella and the trochleus.
Okay, just seating it.
Exactly. Once contact was confirmed, the primary load was ramped up. The 1,000 Newton quadriceps load was applied, simulating the high force demands of deep flexion, like rising from a low chair.
And that 1,000 newtons, that was distributed realistically.
Yes, very important. It was distributed among the heads of the quadriceps tendon based on their known physiologic cross-sectional areas, referencing the work of Fairmond and his group. So it ensures the load distribution is as physiologically realistic as you can get in a model like this.
Let's talk numbers. The results are where the story truly changes. The researchers focused on this metric called highly strained volume, or HSV, and they defined that as the volume of bone experiencing strain above a critical threshold of 0.5%.
And that 0.5% threshold isn't arbitrary. For the audience, remember that the yield strains, that's the point where permanent plastic deformation begins, for trabecular and cortical bone are generally reported to be somewhere between 0.6% and 1%.
Okay, so 0.5% is getting close to that failure point.
It's right on the boundary. By setting the threshold there, the researchers are identifying the volume of bone that is under critical stress. It's bone that is on the verge of failure or at least significant microdamage accumulation.
So we're basically mapping the volume of bone that is shouting for mercy.
That's a good way to put it. And the dominant mechanical cry is compression. The overall mechanism in deep flexion is compressive overload. The bending moment created by the quad load, compressing the patella against the trochlea, means the resulting highly strained bone volume in compression was 3 to 4 times larger than the volume in high tension.
Which reinforces that TKA failure is typically a compressive failure of the bone stock under the component.
Precisely.
Now for the dramatic comparison. The difference between the natural and the implanted patellae was pretty negligible in early flexion, say below 40 degrees.
Right.
But as you ramp up the load and you get into deep flexion, the difference is just astronomical.
Astronomical is the right word. At 120 degrees of flexion, the study found an average increase of 190% in the highly strained volume after implantation.
190%.
We are talking about nearly tripling the volume of bone that is on the verge of failure just by removing the natural articular surface and implanting a polyethylene button.
That average of 190% is shocking enough, but what really captured my attention was the massive variability between subjects. The range of increase was what? 20.5% on the low end, all the way up to a staggering 465% increase.
And that range is the smoking gun. It's the whole justification for subject-specific modeling. It suggests that the TKR component itself isn't the primary variable.
What is the host bone?
It's the intrinsic quality and geometry of the host bone. The surgery, which is standardized, just acts as an amplifier. If the host bone is already robust, the stress increase is minimal, that 20.5%. But if the host bone is structurally porous or poorly supported, the stress is amplified by 4 or 5 times.
Which reframes the problem entirely. We aren't just trying to prevent surgical error, we're trying to mitigate the mechanical failure of inherently weak patient bones.
Yes.
And you can see it so clearly in figure 22.4, the bottom plot. The differences become statistically significant, p less than 0.05, precisely in that zone of high load, above 80 degrees of flexion.
Confirming that deep flexion activities are the risk zone. And that variability is precisely why we needed to look at this subject-specific data. Even when you standardize everything, the load, the component, the alignment, the highly strained volumes in the implanted state, varied from 0.5% all the way up to 23.4%. You see that in table 22.1.
So a single standardized surgical technique will produce wildly different mechanical results depending on whose knee you're operating on.
That's it.
But the study also found a strong proportional correlation, R equals 0.85, between the natural and the implanted highly strained volumes. What does that R of 0.85 really mean clinically?
It means that if a patient comes in with a patella that already strains easily under normal physiological load, that is the same patella that will experience the highest stress increase after you implant it.
So the surgery doesn't create new weakness?
No, it dramatically exposes and amplifies the pre-existing weakness. It confirms that if you have a structurally brittle patella, the surgery will simply push it over the edge faster.
This is invaluable for preoperative screening.
It is, because the intrinsic material properties are fixed. We can potentially identify these brittle sandstone patellae from the strong porcelain ones before we even start.
So the story deepens when we look at the location. The strain doesn't just increase, it moves. It shifts to a new weak point. In the native natural patella, where was the peak compressive strain located?
Predictably, in the native knee, the peak compressive strains were located in the softer cancellous bone directly underneath the primary proximal contact patch. That's where the patella sits against the femoral trochlean flexion.
Where the load is transmitted?
Where the load is transmitted and the bone buckles slightly inward.
But once you implant the component, that stress map changes dramatically. The implanted strain location shifts to 3 primary areas, right? It goes medially, it concentrates around the pegs, and some at the distal nose of the patella.
The focus around the component pegs is expected. I mean, they're stress risers. But the most revealing shift is that medial focus. When they compare the volume of bone straining around the pegs, it increased from 7.3% to 9.3%.
Which is a concern, but not statistically significant here.
Right, not in this small sample. The real statistical powerhouse was the quadrant analysis.
Okay, let's break down the quadrant analysis. They centered a division line over the component midpoint and looked at superior, inferior, medial, and lateral volumes of critical strain. That's figure 22.6.
Correct. In the native patella, the distribution was surprisingly even from medial to lateral. But the strain was higher superiorly just due to the anatomy of the native contact path inflection.
Okay.
However, in the implanted patella, the superior-inferior strain became more balanced. The component forces strain lower down, but the difference exploded medially versus laterally. The strain was now significantly and statistically larger medially than it was laterally.
So that medial quadrant is the new failure hotspot, and it's driven by the surgery?
It is. The largest difference between the two states was in that medial region, being less than 0.05. The highly strained volume there more than doubled. It jumped from 6.5% of the medial quadrant bone volume to 13.7% after the resurfacing.
And conversely, the superior quadrant actually saw a decrease.
Slight decrease, yes. It confirms that the TKR component fundamentally restructures the stress path. The surgery moved the weakest link to the medial side.
We have to know the structural explanation for this. Why the dramatic medial shift? You said it wasn't about contact pressure, so what was the driving factor?
It boils down entirely to the inherent material science of the bone and what we removed during surgery. The researchers did a sub-analysis and found that the bone in the medial compartment was significantly intrinsically softer than the bone on the lateral side.
Intrinsically softer? By how much?
Quantitatively, the average Young's modulus was measured at 2.6 GPa medially versus 3.7 GPa laterally.
That's a difference of over 40% in stiffness.
It's a huge difference. It means the medial side of the patella is just naturally weaker and less dense than the lateral side.
Okay, so in the natural state, the bone is inherently heterogeneous. It's weaker medially. Why didn't it fail medially before the TKR?
Because of the stress shielding provided by the dense subchondral bone and the cortical shell. In the native patella, that dense articulating surface acts like a structural helmet. It distributes the load evenly and protects that softer, central, medial cancellous core. Once we resect the patella for resurfacing, we remove that structural helmet. The component, which acts like a polyethylene stamp, then concentrates the load directly into the underlying, intrinsically soft medial cancellous bone.
The load concentrates where the stiffness is lowest.
Always.
That is a fundamental mechanical realization. We are removing the protective shell that compensated for the natural structural heterogeneity of the bone, and so the soft spot becomes the failure spot.
Yes.
You can see this relationship mapped out so clearly in figure 22.7b, which shows that soft medial region just lighting up with critical strain after implantation.
And it offers a perfect biomechanical explanation for why some patients who might have had a technically perfect alignment still experience medial component loosening or a subsequent fracture. The bones simply cannot handle the focused, amplified strain in that naturally weak region.
So we've established the mechanical consequences: increased magnitude of strain and a critical shift of that strain location to the intrinsically weaker medial quadrant. Now we have to move to the ultimate clinical goal:
Prediction.
prediction. We need simple, measurable parameters we can pull off a preoperative CT or X-ray without having to run a 140,000 element FEA model on every single patient.
The goal is to tie this complex physics back to simple geometry. And the strongest, most clinically applicable relationship the researchers found was an inverse correlation between the final implanted highly strained volume and the volume of remaining bone after resection.
An inverse correlation.
A very strong one. The correlation coefficient was significantly robust. R equals negative 0.704.
An inverse relationship of R equals negative Bang vowels 174. So that suggests that for every unit of bone volume we remove, we exponentially increase the strain in the bone we leave behind.
That's it. The less bone remaining post-resection, the higher the predicted risk of structural failure.
This is the practical check on our surgical technique. It means that the single most controllable factor, besides alignment, is bone stock preservation.
Exactly. This correlation implies that if we know a patient's preoperative patellar dimensions and we can calculate the final remaining bone volume based on our planned resection depth and component size, we possess a strong predictor of post-TKR patellar strain risk.
The total volume of bone remaining is a measure of the mechanical reserve capacity.
Precisely.
Is a R of negative back 0.74 high enough that we should start mandating preoperative patellar volume analysis in every single TKR case?
You know, given the gravity of the complication, that 45% infection rate after fixation we talked about, I would argue yes. This data provides the biomechanical justification. While we often focus on keeping the overall postoperative patellar thickness within a certain range, the volume of remaining bone is a more comprehensive measure than just thickness. A small, thin patella, even if it's resurfaced to the correct thickness, might have a much lower volume of remaining bone and thus a higher predicted strain than a large, thick patella that underwent a deeper resection.
Did any other geometric factors correlate with risk?
Yes, but less powerfully. A weaker correlation was found between the implanted, highly strained volume and the postoperative patellar thickness alone. That was R equals negative 0.61.
Okay, so thickness is part of the story, but remaining bone volume captures the structural integrity better.
It does, because it accounts for the entire three-dimensional geometry and the cancellous core we're relying on.
This insight dramatically impacts our surgical decision-making. If we flag a patient preoperatively as having that brittle sandstone patella-high natural strain, and we know, based on their anatomy and our required component, that they'll be left with a low volume of remaining bone.
This patient should be handled with extreme caution. It should trigger a mandatory reevaluation of the operative plan. It could guide the selection of a specific implant design, maybe one with smaller pegs, or one that requires less aggressive resection. It certainly reinforces the need for meticulous symmetrical resection. And potentially, in the right cases, it forces us to strongly consider leaving the patella unresurfaced.
To preserve that crucial protective cortical shell and maximize the remaining bone volume.
This FEA is shifting the focus from simply achieving alignment to preserving mechanical strength.
Now, we do have to address the engineering caveats. No model is perfect, and we have to be critical of the necessary simplifications. What are the key limitations we need to keep in mind here?
A critical limitation is in the interface modeling. The researchers assumed perfect bonding between the cement layer and the patellar bone.
Which is never the case in reality.
Never. In clinical reality, we know the cement mantle is rarely perfect. Imperfect bonding creates local micromotion and highly concentrated stress risers right around those component pegs. Had they modeled an imperfect interface, the strain concentrations around the pegs might have been significantly higher than the 9.3% they reported.
And second, we already mentioned the loading conditions were isolated PF joint mechanics, not a full body weight-bearing simulation.
Correct. While the forces transmitted were physiologically reasonable, simulating a deep knee bend in isolation is not the same as simulating a patient negotiating stairs or rising from a chair under full body weight. This is why the study wisely focused on comparing the relative change natural versus implanted, rather than predicting the absolute magnitude of strain needed to cause a fracture.
So the model is a robust tool for comparison and risk analysis, not absolute fracture prediction.
Very well put.
So we've used this high-fidelity computational data to confirm the mechanical reality. TKA resurfacing is fundamentally a trade-off. We eliminate the articular pain, but we introduce a massive structural vulnerability.
We've confirmed an average 190% increase in the critical stress volume, and we've definitively located the new failure zone, that intrinsically softer medial quadrant exposed by removing its protective cortical dome.
The final takeaway then for the surgeon is that preoperative planning must prioritize bone stock preservation. That powerful inverse correlation, R equals -0.74, means the geometry we can assess on preoperative imaging is our most reliable crystal ball for predicting postoperative mechanical failure risk.
We must treat the volume of remaining bone as a critical life sign for the patella.
Mm.
Now, for the final provocative thought that takes this data straight back into the operating room with you, this study demonstrated these results, assuming perfect neutral alignment, the ideal textbook scenario.
Which we know isn't always reality.
It's not. We know that in surgical practice, slight component malrotation or subtle maltracking minor variables that might not be clinically symptomatic right away are common occurrences.
So if that medial quadrant is already compromised, it's intrinsically softer and now exposed to double the critical strain, what happens when we introduce even a minor rotational error?
Exactly. With a slight malrotation, which shifts the contact pressure just a few millimeters medially, exacerbate the strain concentration in that already vulnerable medial bone. We would push that stress volume past its absolute yield point, turning a manageable structural risk into an inevitable catastrophic failure.
A failure we might blame on the patient's activity level.
When in reality, it was predetermined physics. The next time you look at a 140,000 element mesh or a real-life patella, remember that stress accumulates silently, and structural integrity is a zero-sum game. You have to account for that intrinsic soft spot.